Good afternoon. What a day yesterday was and what a conference it is. At the outset, I'd like to thank our chief guest, Dr. Sammati Jadhav madam, and our guest of honor, Dr. Uma Nambiar madam. Despite their busy schedule and no air connectivity to Sholapur, Dr. Nambiar madam traveled overnight. At 2 o'clock she landed in Pune and by road she came to Sholapur. That's her enthusiasm. Similarly, Dr. Sammati Jadhav madam, who is so busy with her duties, and both of these ladies, on a very short notice, a short notice of just 15 days, they agreed to participate in this function and grace our occasion. What can I say about the faculties? These eminent people from every nook and corner of the country. They, again, there was no air connectivity. Still, every one of them did not bother. Came by road, came by train, whatever the means I provided. They came, they studied hard. In fact, for the last few days, they have formed their own groups. They coordinated amongst themselves like school boys. They created their WhatsApp group and just to teach you. This, see the zeal in them at this age. They not only want to learn, they want to teach you. Then I cannot thank enough for my supporting team, Dr. Pradeep Singhal, Dr. Rudrakshi, Dr. Vinu, Dr. Rizwan, Dr. Kedar Karpe, who have been silently helping me, without whom I don't think we could have got this response. And ultimately, the success of the conference is you. You people. What an overwhelming response. We had to refuse registrations. We crossed 500 registrations. And literally, I apologize to those whom I could not accommodate. Your enthusiasm motivated the faculties and it brought out the best in them to teach you. So your participation, I think, will go down in the history because what I say, the seed of AI is sown in Solapur. And the movement and the campaign that it has started, now from Solapur, it will spread outwards to rest of the country. Thank you all. Now coming to the topic, my tryst with AI. I'm an AI student. I did course for last 2 years. I am learning through YouTubes. Then I did a course with Indian Institute of Science, Bangalore, studied hard. Every weekend, 6-7 hours, gave their exam, passed that exam. Then I did a course with Indian Institute of Healthcare and Research Management, Bangalore, where Dr. Satish Rath, Pratichi madam were our mentors. Gave exam, passed that exam. Then recently, Amit Day's group, Doctors AI, we have been, for last 4 months, they have been teaching us. And just last week, we got our results and got our certificates. So I am an AI student. Now I am turning into an AI researcher because I have just been appointed as a PhD co-guide by Pimpri-Chinchwad University for working on a project, Cine Angiogram. And that I intend to do for prediction of advanced progression of coronary artery disease from the initial coronary angiogram. And that's the project I intend to do. And no, that doesn't matter. And incidentally, yes, I also do interventional cardiology for living. Okay. This I've been doing, but now with Chinmay coming over and taking my part, perhaps I may have to shift to AI for my daily bread earning. Coming to AI and ECG. ECG has always been my first love. Ever since I entered my medical college, right from physiology, ECG was my first love. I read everything in ECG right in the first year, all physiology books. I read how the ECG is generated, why a particular lead is producing which type of morphology. And then this love grew further when I entered medicine. In fact, the love of ECG prompted me to take MD medicine. In fact, during my times, pediatrics was the hot branch, and all the toppers were going to MD pediatrics. But this love of ECG made me to take MD medicine. During our MD medicine, ECG was the only investigations, and we used to, me, my colleague, Dr. Ponde, we used to toy with the ECG. And that was the only investigation, and we used to predict the clinical diagnosis with ECG and all sorts of a thing. And in fact, this ECG was the one which helped me to crack entrance as PGI Chandigarh and get into the DM course. There was only one seat at PGI Chandigarh for all over the India. And that I could crack only because of my ECG knowledge. So that's prompted me to take DM cardiology. In fact, I was getting DM neurology, but I waited for 1 year till I got DM cardiology. Yes, today ECG is, for the cardiologist, is losing relevance because I think that today's cardiologists use ECG only to see if there is angiogram is needed or not needed. But there is a silver lining. A new branch, electrophysiology, is coming up. This electrophysiologists, they have refined ECG diagnosis. They have taken ECG to next level. And now they are using ECG for interventions and treating patients. And this, my son has become Chinmay is now electrophysiologist. And I'm finding that he is interpreting ECG better than me. So my ego is hurt. So I have to still stay relevant. So to stay relevant, in the meantime, I read some articles on ECG in AI. So I thought, yes, this is a field which very few will catch up. So now that I'm losing my relevance in general ECG, why not go into AI? And thus my journey with AI began. Now the common question which is asked is, what is the difference between computer interpretation of ECG and AI interpretation of ECG? Everyone tells me, see the ECG machine, GE, Philips, they give you ECG diagnosis. Why do you need AI? The computer interpretation of ECG is based on rules. For example, SV6 plus SV1 plus RV6 is left ventricular hypertrophy. That computer tells you. But as we know, many thin chest wall persons, they have this formula, but they don't have LVH. Similarly, very thick chest wall persons, they don't fulfill this criteria, but they have LVH. So how does the AI differ? In AI, all the proven patients of left ventricular hypertrophy on echo, these ECGs are given to the AI model, and AI itself learns the patterns. It itself finds out the signature in the ECG. So what is LVH? So the ECG diagnosis of LVH by AI is more accurate than a computer interpretation. And how does AI do it? Now we look at the ECG with PQ, RST and these intervals. How does AI look at the ECG? AI look at these numbers. A normal ECG, I have put up only 35 rows, but there are 5,000 rows. So 12 leads is 60,000 points. So minimum 60,000 points are looked at by AI model to make an interpretation. And we look at only 5 waves. So naturally what AI can look, we cannot look. Now going to the clinical applications, I think Dr. Azhar Wahab in the morning told, yes, one of the first clinical applications which is coming into the practice is prediction of left ventricular function on ECG. And the Mayo group has done exceedingly well, where they could diagnose with a very high accuracy sensitivity and specificity, left ventricular dysfunction, less than 35% ejection fraction only on ECG. Now, for example, if we are given this ECG and asked, what is the likely to be ejection fraction? Does this patient have LV dysfunction? I don't think any cardiologist will be able to tell. But the AI said there is a high probability that this patient has left ventricular dysfunction, and when actual ejection fraction was 18%. Now, another important thing. Now, this ECG, when was given to AI model, it said this patient has a low ejection fraction, but actual ejection fraction was normal. So it was said that this is false positive. It has falsely diagnosed left ventricular dysfunction. But this patient, in next few years, went on to develop left ventricular dysfunction. And not this, such many instances were recorded. When initially AI model said there is no left ventricular dysfunction, subsequently these patients went on to develop left ventricular dysfunction. The 30% of the patients whom AI model said there is left ventricular dysfunction, although left ventricular function was normal at that time, these patients went on to develop left ventricular dysfunction. So this is called as a previvor concept. Like an astrologer, it can predict whether you will develop future left ventricular dysfunction. Not only can tell whether is left ventricular dysfunction today, but it can predict whether you will develop left ventricular function tomorrow. That is the value of ECG. In fact, this stethoscope will soon come into the market, which is AI enabled with single lead ECG, and this can be used in casualty as a triage, whether the dyspnea is because of the respiratory cause or because of the cardiac cause. Now, another important indication is silent atrial fibrillation. As you know, many ischemic strokes are because of atrial fibrillation. And this atrial fibrillation is intermittent, silent. The moment you go to the doctor, the ECG is normal, sinus rhythm. They have intermittent atrial fibrillation, and this cannot be diagnosed. Consider this 65-year-old female. She had a stroke, ischemic stroke in 2014. She was extensively investigated. She did not have AF. She was not anticoagulated. She had another stroke in 2020. Again, no AF. But few months later, she developed AF. Just imagine, if this AF would have been picked up early, at least the second stroke could have been prevented by anticoagulation. Consider this example. This ECG here, when was given to the AI model, it said only ventricular ectopics, no silent AF. Few years later, this ECG is similar except for the ectopics. When AI model was given this ECG, it said silent AF present. See, this is a sinus rhythm, but it has said silent AF present. And few years later, she went on to develop atrial fibrillation. So this is the importance of picking up a silent AF on a normal sinus rhythm. Again, this is coming from this Mayo Clinic group with a high sensitivity and specificity. Now, another important indication is hypertrophic cardiomyopathy. Yes, you have certain ECG criteria for hypertrophic cardiomyopathy, but 10% of the patients, ECG is normal, and they have hypertrophic cardiomyopathy. Now, you must have seen many persons, healthy persons, before their fitness, they want to run marathon, they want to get recruited in military or in police, and they come for fitness. We ask symptoms and we just do ECG, and that's all. We stop there. Remember, 10% of them, they have 10% of them, they have hypertrophic cardiomyopathy. And this hypertrophic cardiomyopathy can be picked up with a very high accuracy on ECG. Now, see this patient, a 23-year-old female with syncope. If you are any expert cardiologist, even electrophysiologist, if it's asked, this ECG will be labeled as normal. And she will be subjected to extensive investigation, electrophysiological studies, extensive Holter monitoring, and maybe we will come out with nothing. But when AI model was given this ECG, it said there is a high probability that patient has a hypertrophic cardiomyopathy. So no fancy investigations, no electrophysiology. On AI model is going to tell us that this patient, the cause of syncope is likely to be hypertrophic cardiomyopathy. Now, not only the AI model can diagnose hypertrophic cardiomyopathy, it can distinguish. For those who are doing echocardiography, you know, now echo itself, it is very difficult to distinguish this hypertrophy. It is because of the hypertension, aortic stenosis, infiltrative disease like amyloidosis, or it is physiological in athlete's heart. On echo itself, it is not possible. But ECG can tell you this hypertrophy, whether it is because of hypertrophic cardiomyopathy, amyloidosis, aortic stenosis. So that's the value of ECG. Now this is another important concept. It's found that with a very high accuracy, ECG can tell you the age and gender of the patient. And it is said that ECG age is the patient's biological age, not the chronological age. Chronological age is what we measure from our date of birth. But the biological age is the tissue age. Okay, that depends upon whether you have comorbidities, whether you have diabetes, hypertension, ischemic heart disease, malignancy. So that's the biological age, and it's found that the ECG age correlates with the biological age. And just to give you an example, it said that if the ECG age is more than 7 years than the chronological age, then these patients have a higher mortality. Okay, so that is the importance of measuring ECG age. To give you an example, this was a 35-year-old obese lady. Okay, this was a 35-year-old obese lady. She had 106 kg weight. Her BMI was 39 and her ECG age was 40. She was 35-year-old, but AI ECG age was 40 years. So there was a gap. Over next 2 years, she lost 10 kg. Okay, so from 35 years, she went to 37 years. And now her AI ECG age is 36.4. So this is an important motivation that you can reverse your biological age with lifestyle management. So this is one of the important messages that one has to take. Another interesting example, this is a Dr. Friedman's slide from Mayo Clinic, from one of the audiences. Now this is, you'll see on the x-axis, there is a chronological age. On the y-axis, there is ECG age. As the chronological age increased, ECG age also increased till the point of 53. And suddenly the biological or ECG age suddenly decreased. And he asked the audience, what could have happened? And he got funny answers. Someone said he got married. Someone said he got divorced. But what had happened? That he underwent heart transplant and he got a heart of a younger patient. Okay, so that's why the ECG age came down. This was the news just a few days ago, where it was shows that Trump's ECG age is 14 years less. When I read this news, till now I was using term biological age. After reading this news, I said it is cardiac age, because I don't think the brain age and cardiac age are matching. Also, in many conditions, non-cardiac conditions also, ECG can be useful in their diagnosis. And yes, as has been discussed so far, that there are challenges, there are limitations. Just to give you an example. Now this is an ECG. When our naked eye, you see there is a single ECG in red. But if you magnify one of the portions of the ECG, there are two overlapping ECGs, one in the blue, one in the red. So just introduce a noise in the blue and there was red ECG. If AI model was given that blue ECG, it said that this patient is a male. If AI model was given red ECG, it said it is a female. So little change in the data. It is very important. The quality of the data is important. Garbage in, garbage out. So your predictions totally go haywire. If your data is wrong, then your output is wrong. As you will see, there is no Indian data. Most of the data we are borrowing from the Western countries, especially USA, and all this, most of the algorithms which I have showed you are coming from Mayo Clinic. So I said, why not take a baby step in ECG? Because I have more than 60,000 patients in EMR, longitudinal study. I have more than 2.5 lakhs ECGs in a digital format, that is those numbers, okay, binary format. All the ECGs, more than 90% have their echo reports. They have their clinical diagnosis. In addition to this, I have more than 10,000 echocardiograms in my record, their videos, as well as still frames. I have more than 35,000 coronary angiograms, their CDs with me. And more than 10,000 angioplasties, their CDs with me. So with this, I intend to develop some India-based algorithms, as we will see later. So we saw silent AF. So in fact, one of our engineers here, Mr. Siddesh, is there from Lenec Technology. With him, I developed an algorithm where this, for prediction of silent AF, and this paper I published in Sydney conference, APHRS, 2 years ago. Similarly, I published this in ACC in Singapore. Now, just to give you an example, this is my 20-year-old patient, regularly coming, religiously visiting me for every 6 months. Absolutely no symptoms. Now, when I developed this algorithm and I put the algorithm on him, it said there is a very high probability of atrial fibrillation. I was surprised. He never had any symptoms. He was just taking routine follow-up. So what I did, I put him on a 7-day Holter. Okay, I put him on a 7-day Holter and it picked up this atrial fibrillation. So one short burst of AF was there on 7-day Holter. Now this is another interesting patient. This patient came to me in July. His atrial fibrillation probability was 49.14%. He came with chest pain, typical angina. His AF probability was 74.15. He was in acute coronary syndrome. His troponin was positive. I hospitalized him, did his angioplasty, discharged. And in December, you'll see his AF probability came down from 74% to 53%. So this gave me a confidence that my AF algorithm is working well. In fact, we've had just collaboration with Max Saket Institute, Delhi, where they have a very high workload of atrial fibrillation. I'm trying to validate that algorithm with them. And this is the architecture for AF algorithm for which I have filed a patent. Now, left ventricular function. You heard in the morning about ejection fraction. Yes, ejection fraction has been well studied abroad and the algorithm is out and it's coming into the practice. Global left ventricular strain is a newer marker for left ventricular systolic function. And it is more important than ejection fraction. If you have seen echo reports, echo done today of that patient and tomorrow of that patient, your ejection fraction changes. One cardiologist does echo, other cardiologist does echo, ejection fraction changes. So this is operator dependent EF. It is a preload dependent. But look, GLS, which is another important marker of left ventricular systolic function, it is operator independent, load independent. Okay, so whoever does it with the same machine, GLS is roughly the same. So I decided to see whether ECG can predict GLS. And this is for the first time in the world. Now, to give you an example, this is a patient who had undergone heart transplant. He came to me somewhere in May, and his normal GLS values are more than 16. Okay, normal GLS values are more than 16. Forget about that minus. So 18, 19, 20, they are normal values. So more than 16 is a normal value. Less than 16, less than 10 is a severe airway dysfunction. So this patient came to me in May. His GLS was normal. He came to me with dyspnea 6 months later, and my ECG predicted GLS was 6.9. I was surprised. Suddenly, why it went down? So I did his echo, and it showed the actual GLS, which was normal initially, indeed had got down to minus 6.9. So my predicted was minus 7.5, actually also had gone down, ejection fraction had dropped down to 23. So that model was also working very well. Now this is another example. This is a lady who came to me in January last year, and this was her ECG. She had a low ejection fraction. She had dilated cardiomyopathy, a low ejection fraction. Okay, she was put on the treatment. 6 months later, so this was January, 6 months later, suddenly there were minor changes in ECG, but suddenly my predicted GLS, ECG predicted GLS was normal. I was surprised. A dilated cardiomyopathy patient cannot have a normal ejection fraction in 6 months. I was surprised because it was so low. I thought my model is making mistake. So I put her again on the whole echo, and indeed, her GLS had normalized. Her ejection fraction has normalized. So this model is performing exceedingly well. Another, just a few days ago, this patient came to me with nearly normal looking ECG. He had effort dyspnea. And I was about to put him on treadmill test to know whether it is ischemic. He was diabetic, above 60, so I thought I will do a stress test. But I saw the predicted GLS, it was low. So I thought I should do echo first. And I did echo, and that patient had a significant, GLS was low, ejection fraction was only 12. See the ECG, normal looking ECG, absolutely. And EF was only 12. So this is how I had to change the strategy. Did her echo, otherwise he would have crashed on the treadmill. Now this was the paper which I presented recently in American College of Cardiology, in New Orleans. This was the original article, and in fact, the engineer, Mr. Sudhanshu, is here, who has developed this model. We have filed a patent for this also, and we are expecting that this should definitely, we should get a patent, because this is the first time in the world, no one has done GLS so far in anyone in the world. Now, this is the ECG machine, which is a mobile size ECG machine, which I have developed, and we have got patent for it. Mr. Prashant Sadavarse and Mr. Sriram Kulkarni, we three have developed this ECG machine. This is the machine, if you can see in my hand. This is a mobile size ECG machine, which we have developed. And I intend to integrate all the algorithms which I am developing into this ECG machine. And you saw that, yes, Mayo Clinic is giving a dashboard. So I thought, why not me also give a dashboard? So this is the ECG generated from my ECG machine. And we have that ECG predictive analysis with the atrial fibrillation probability of 25%, the GLS probability of -12. So I intend to integrate this ECG machine, these algorithms in my machine, and it is under certification. Maybe in a month or time, this machine will be commercially available. In fact, I have formed parallel registry, with my name, with acronym, prospective and retrospective all-comer registry of AI ECG algorithm for predictive evaluation. So all this registry I have registered with CTRI India, and all patients who walk into my OPD, they are subjected to these algorithms. I enter them into my EMR and check the values and then see whether my algorithms are working or not. In fact, these are the courses which I have done. After these courses, I thought I took some inspiration from the teachers like Dr. Atul Tiwari and all, and then I said, why not develop some tools? Of course, they are not of that high caliber that Dr. Atul Tiwari and others are doing, but may some basic baby tools which I am developing. Now, this was the first tool which I developed, ABG analyzer, because the residents, they need ABG. So here, entering the values of pH, PO2, PCO2, electrolytes, weight and all, when you enter them, this, now you will see this, the values are entered. The moment the values are entered, this not only gives you the diagnosis, it tells you the cause of the disease, what has caused this abnormality. Not only that, it tells you the management, ventilatory management, which medicines to be given, in what dose it can be given. So we'll see, what are the comorbidities patient have, you all have to, then you see generalized protection. So this is a critical imbalance, metabolic alkalosis plus respiratory alkalosis, what was expected PCO2, what is actual PCO2, what is the pathophysiological context, see all it comes, and what actions you need to take, what actions you need to take, what hyponatremia, what dose it can connect hyponatremia. So this algorithm I made first. Then vaccine schedule, of course, Dr. Deepak is here. He is more, I think, the expert in this. But for adults, I have made a vaccine schedule because many of my patients, they have comorbidities. I won't show that. But this, now as you have been seeing, EMR is very crucial. So I thought of entering into the field of EMR, whether I can integrate some of the modules into EMR and automate certain things. So developed something. Now this is a diet. Many of my patients have multiple comorbidities. And you will see here, after you enter, whatever the language you select, because many of our patients in Marathi, language you select, then enter whether it's a gender, then enter their height, weight, then enter their preferences, they are vegetarian, non-vegetarian, vegetarian, occasional non-vegetarian, their residence, which state they reside, then that is a choice of cuisine, they want North Indian, South Indian, West Indians, the cuisine, whether they have any medical conditions, everything, because many of my patients have multiple comorbidities. So you choose that, and after that, it gives you the diet, personalized diet, and this diet tells you what to avoid, what not to, it gives you multiple options. What they should eat in the language they want. It tells you about the exercise which they can undertake. It tells you about yogasana it undertakes. It tells you about the calories they need to lose. They use the alternatives. If you don't have to take roti, you have to take what. So this is an extensive diet planner that I have made. Now another important is, as has been said, Dr. Prasad Rajan said, yes, drug interactions. Yes. And drug dosage adjustment. That's very important. And we have polypharmacy, we are used to prescribing a lot of drugs and we don't know interactions. So I have developed, yes, there are certain apps available which can tell you about drug interaction, but I thought I should do more. So what I did, now here, this is a dashboard where you enter 2 drugs and it will tell you everything about the interactions. You enter a drug and diagnosis, it will tell you whether you need to reduce dose and all. But why I did something more. I thought I would analyze the prescription. So you take a prescription of the photo, you will see that. So this is the prescription where there is a diagnosis and multiple drugs. You upload that prescription, quickly it analyzes it, and it tells you clopidogrel, caution. Why there is caution? Because it is with aspirin. Then elderly, rivaroxaban. In elderly, you have to be cautious. Rivaroxaban with clopidogrel, you have to be cautious. So it tells you about the comorbidities, where you have to be cautious, where you have to reduce the dose. Elderly, frail, reduce the dose. Torsemide, you have to be careful, can have a relief. So all these drugs, it catches and it tells you whether there is interaction, whether you need to reduce the dose, and what problems you can have. This just take a photograph of the prescription and you have this running. Now this is another important area. Now another important area, as you know, many of our patients come with big reports, big file full of reports. And if we have to see the reports individually, multiple ultrasound reports, multiple blood reports at many hospitals, it will take at least 20-25 minutes for every patient. So I thought, why not develop an app which will give us a summary of all the reports. Now this is an app, you will see, this is the app. You take the photo of all the investigations which have been. So biochemical investigations, radiological investigations, sonography investigations, CT scan, MRI, you take just photographs. So multiple, this is around 20, 25 photographs you'd say, and it gives you 3 formats. It tells you a structured format where it tells you which investigation was abnormal. MRI was abnormal. It tells you what was abnormal, what was normal. Then it gives you in a story format. This is story format, what this patient's wrong is. Then it can convert into the language of your choice for patients. So in Marathi, it will explain the patients what all investigations have been done and what he needs to see. Now you will see in Marathi, you have this patient summary in Marathi. So this is different languages. So in Marathi, it tells you for patient, and I can share it on WhatsApp to him what all investigations mean. Now, ambient scribe. So this is the recent thing which we are developing with Mr. Sachin Chaugale. Here you have patient queue. When patient walks in, you record the complaints. The recording patient is speaking. Probably you are not able to hear. The sound is slightly not audible, but patient is speaking in Marathi. And in seconds, you have AI generated summary in structured format, in English, and not only it gives you summary, it tells you what action needs to be done, what investigations need to be done. So all is this I intend to integrate with EMR. So that is the EMR which I plan it to integrate with. Now these are my upcoming projects. Biological age prediction, Mr. Advait from MIT is there. And we intend to develop age prediction from ECG age, not biological age. Then with Mr. Siddesh, with the ECG is normal or has heart attack. That's a basic screening. Then with, again, Advait, we plan to develop digital cardiac twin. Then this is the PhD project which I have assigned, where patients have undergone serial angiographies. So whether the first angiogram can predict whether this patient can have future progression of coronary artery disease. So these are the projects which are in the pipeline. Of course, I have talked big, but this would not have been possible without collaboration with these people. IIT Jodhpur, Mr. Sudhanshu is here. IIT Roorkee, that team is not here. Lenek Technology, Mr. Siddesh is here. MIT Pune, Mr. Advait is here. Design Tech, Mr. Sachin Chaugale is here. And of course, my Spandan, my OPD staff, my Ashwini hospital staff, the technicians, nurses, my house officers, they have been of tremendous help in validating this. And not to forget the least, my wife Neha. Without her patience, without her passive support, without sacrificing her family life, I don't think I would have achieved this. Thank you.
Thank you so much, sir, for that wonderful talk. I think he deserves a standing ovation for this. Can we continue the round of applause? For his tireless work since past 6 months, he has been working on this conference day in, day night. After finishing his busy OPD and work, he has been continuing to do work on this conference. As rightly said, the future belongs to those who can imagine it, innovate for it, and inspire others to build it. And Dr. Parale embodies all three. I request the chairpersons to felicitate Dr. Parale.
Yeah, here I would really like to speak with the audience. I'm really, really inspired, sir. You're a young innovator. And I have actually, thought of, what do I call him? So I'll call you the ECG man of India, like after Padman. But then there are so many other things that you are doing. You have done the APG analyzer and the prescription analyzer and whatnot. So you are, AI, generative AI yourself. So thank you so much for a wonderful elaborate talk. And I especially liked you to, talk about your wife and family. It's a very rare kind of, thought process.
Neha ma'am, please come on stage.
So every time we talk about the integration of AI with the clinician, we look for that success story, that particular story that will inspire somebody. So if you can just come here, please come here. Yeah, please come here. One
So
individual will
Chinmay
inspire
and
100
Tanushri
other
also should
individuals
join sir
to
on
take up
stage.
this innovation. What Sir just showed is through his lens he identified certain lead gaps. And this is exactly how clinicians do. Thank you so much, sir. Thank you not only for bringing AI in ECG, but for inspiring maybe thousands of clinicians across the country and maybe even the globe, if I can say it aloud, to think out of the box and to think how they can innovate using it. Thank you, sir.
So as we felicitate sir, the round of applause should continue for his vision, for his innovation, for his unwavering commitment to improving patient care through technology.
Can we have a
This is
standing
a
ovation, please?
reflection of his foresight,
Ask everybody to stand.
of his dedication and passion of shaping the future of healthcare. Thank you so much.